Dialysis emergencies. The first one, the most common and the scariest in my opinion, is hyperkalemia. It's commonly triggered by missed hemodialysis, hemolysis, or tissue breakdown. There is a spectrum of findings on your EKG, but if you see peaked T waves, shit your pants and start managing them. Otherwise, you might see a progression to a wide QRS, a sine wave, or even AFib. So what do we do for management? So immediately you want to stabilize the cardiac membrane, and you can do this with calcium gluconate if they have a peripheral IV. This is going to be 1 to 3 grams. I prefer 3. And then calcium chloride if they have a central line. You can do 1 gram for this. Next, you want to shift K into their cells. So you can do this with 10 units of insulin and IV dextrose. You'll also want to give them albuterol meds and then sodium bicarb if they're acidotic, but I don't commonly practice this. And then think about removing the potassium. So dialysis is definitive. If they still make urine, you could consider loop diuretics, and then you could also consider cation exchangers like Lokelma, but this is very slow acting, so it's not really useful in the ER setting. My next favorite emergency, volume overload leading to pulmonary edema. So these patients often miss dialysis or they have some dietary indiscretion leading to volume overload and acute pulmonary edema. When I was in New Orleans, patients would come in and be like, I went to a crawfish boil and now I can't breathe. And I'm like, guys, the salt. Luckily they were in the right place. So how did we manage them? If they're hypoxic, you can consider BiPAP because that positive pressure really helps to stunt open these alveoli. Nitrates are really effective at reducing the preload and the afterload, but really you'll want to think about high dose IV loop diuretics if these patients still have residual kidney function. The further they're progressing to ESRD though, the further they're not going to have a great response. So if these patients don't make urine, they need emergent hemodialysis. My next favorite is uremic pericarditis or encephalopathy. This is usually seen in severe azotemia, so a BUN usually greater than 100. Pericarditis, you might hear a friction rub. You might see diffuse ST elevations on their EKG, and this can progress to tamponade. You do not want to anticoagulate these patients, and definitive treatment is urgent dialysis. Encephalopathy, these patients you'll classically see asterixis, confusion, maybe even seizures. They also need dialysis. The answer is usually dialysis. Easy, right? My next favorite, it's kind of a zebra, is dialysis disequilibrium syndrome. This is cerebral edema from rapid osmotic shifts during initial dialysis or a very high BUN. These patients might have a headache, nausea or vomiting, confusion, or even seizures. How do we prevent this? So you'll want to do slow initial dialysis in shorter sessions, and the treatment is supportive, but you might consider mannitol in severe cases. And then finally, vascular access emergencies. These actually can be pretty common. I don't see this often, but you can get a clotted fistula and you'll need an urgent vascular surgery consult for this. They might have an infected fistula or catheter, so you'll want to get blood cultures and start broad spectrum IV antibiotics, remove it if they're septic, and then bleeding after hemodialysis is super common. Apply direct pressure, reverse any anticoagulants, and then you might want to consider throwing a stitch in there or even consulting vascular if you just can't get good control.